Hi, I'm Robin Murray, and also welcome you. We've actually had a first this morning because usually the dean of the medical school says he's going to come and open it and never comes. And we always wait for him for ages. But we had the vice dean who actually came and welcomed you. And spoke English. So this is great progress. So this is the 8th forum, and that has not happened before. So you know we're in 3 venues. That is because the palace, which we usually use for 2 or 3 days, the mayor owns it, and he decided all of a sudden that he wanted it. We had booked it and everything, but strange things happen in the Mediterranean. So that's why we're going to go to the University Department of Psychiatry tomorrow, which will be interesting because we can also see the old mental hospital. So we have our first speaker, who is Allan Young. Allan is the professor of affective disorders and the vice dean of the Institute of Psychiatry at King's College. He's a great expert on affective disorders, particularly bipolar disorder, and has been chairman of or president of most of the bipolar and affective disorder international organizations. So, but without further ado, and he has also the advantage of being Scottish, which is but as well as trying to understand Italian accents, you have to try and understand Scottish accents at this conference.
Grazie, Roberto. So thank you very much to the... Oh, no, yeah. Well, my linguistic skills have their limits, Marta. So thank you very much, and thank you to the organizers, and a particular thank you to Marta for doing everything. Oh, I've got it. Right. I'm going to stand here. Right, okay. I'll move back and forward, actually. So today I'm going to be talking about the future of mood disorders. I brought my wife to Palermo because we take every opportunity we can to come to Sicily. And we were sitting having a coffee yesterday, and this couple of British tourists sat beside us. They'd come off a cruise ship and were doing Palermo in the afternoon, and they were somewhat lost, so we were able to direct them. Having been here for 24 hours longer, we felt like locals. But that's a bit like my talk, what they were doing. They were doing a compressed view of Palermo, and I'm going to do a compressed view of the future treatment of mood disorders because it's particularly interesting at the moment. But some background is in order. So these are my disclosures. So firstly, what are mood disorders? Well, crucially, there's a difference between mood and affective disorders, at least in my mind. This is mood disorders with the great dichotomy between bipolar and depressive disorders. Bipolar disorder, a group of disorders. Depression, and I'll come back to this, is dominated by major depressive disorder, but crucially this splits into recurrent and single episode, and this is almost always glossed over. To my mind, it's a very crucially important point. Affective disorders, in my mind, have a wider meaning and include anxiety disorders, and particularly generalized anxiety disorders. So if we look at the WHO studies about the burden of disease, this is the one graph that sums everything up from 0 right up to 95. So that covers almost all of us. And you can see that depressive and anxiety disorders are the absolute heart of the teardrop of mental ill health, and indeed dominate it in terms of quantity. So depressive disorders, about 37% of the burden, anxiety about 23%. If you add in bipolar, it's over a third of the deleterious impact of severe psychiatric disorders is due to affective disorders. Now this is present across all age groups, although it varies by age. You can see it starts in childhood. Indeed, we have very distinguished child psychiatrists here hiding up the back who are going to tell us more about this. And then it goes through to old age. To my mind, there's two real markers in the age distribution. One is puberty, where I think things change, and the other one is the onset of old age, particularly late life depression, which I think is different from more regular depression. But the key point is that depression and anxiety, and indeed bipolar, are very important. They are, of course, correlated. Now, I was a bit worried about showing this slide because I was sitting in front of Marta and Robin and their postdoc, and they were talking about this on the plane, and I wasn't sure if I was out of date. But the point is, from this paper in 2020, and this field does move very fast, that there are correlations between these disorders. So you can see major depression here correlates very strongly with anxiety. This is particularly generalized anxiety disorder. So the two are almost like Romulus and Remus. Their correlation is weaker with bipolar disorder, but bipolar disorder correlates strongly with schizophrenia. And then there are important correlations, particularly, for example, with ADHD. And this is something that we're perhaps just realizing, that lots of the treatment-resistant depression has a comorbid ADHD, which is very often not recognized or treated. So what is a major depressive disorder? Well, I've put the ICD-10 criteria here because they differed more from DSM-5 than ICD-11. They had a third hallmark symptom of reduced energy, which has been dropped. But really, it's depressed mood or anhedonia, plus a parcel of other symptoms for about 2 weeks. Now, the problem is that this is a very low threshold to reach and includes lots of people. There's a very nice critique by Ed Shorter, who's a very distinguished historian of psychiatric disorder, in the British Journal of Psychiatry in 2014, about the DSM-3 concept of major depression. And the DSM-3 concept is essentially the same as DSM-5. And what Professor Shorter says is that Spitzer and others in DSM-3 parceled in lots of different things into major depression. And because DSM is atheoretical, the old notion of a reactive depression was lost. So it's a big bucket, to use current management speak, and there's lots of different things in it. Now, when we think about the difference between single episode, recurrent, and unremitting, the study by Eaton et al. Is particularly instructive. This is from Baltimore in Maryland. It's a prospective population-based cohort study with 23 years follow-up of about 3,500 people. And 50% had no further episodes, lasted between 9 and 16 weeks. Now, this is obviously a very different group to the recurrent or unremitting group. I continually say when I'm advising about trials to companies, take away first episode. Only look at unremitting or recurrent. And they don't necessarily want to do that, but this group who've a high spontaneous resolution rate fuel the placebo response in studies. 35% have recurrent episodes, 15% have an unremitting course, which is really very, very depressing, if you'll excuse the pun. Risk of recurrence increases after each subsequent episode. If you've got 3 episodes, it's a 90% chance of recurrence. And only younger age of onset significantly predict recurrence. So this is what's happened with psychiatry slowly over the past 10 or 15 years. We've gone from looking at depression in the round, the big bucket from DSM-3, to thinking about treatment resistance, because this is a more defined population. Now, a third of patients will develop treatment resistance according to the definition of a failure to respond to adequate treatment with 2 standard treatments. Some people include psychotherapies here, some people don't. But this is still a big group of individuals. Now, the whole field of developing new therapies is focused in this area. This has come very slowly. It's a bit like an oil tanker turning, but it's a very good development in my view. There's also, this notion of treatment-resistant depression comes from a 1997 paper by John Rush and Michael Thays. John Rush, and here's the reference here, has produced a number of papers. This is one that I'm on with Hamish McAllister-Williams, about reconceptualizing TRD as difficult to treat depression. Now, just to make clear, this is not an opposition to TRD. TRD is a definition that's used in trials and studies. Difficult to treat depression is a clinical approach. And this is essentially more or less what we do in the clinic. We confirm the psychiatric diagnosis, we assess adequacy of prior treatment recommendations, including dose and duration, look at adherence, pharmacogenetics are coming in, and therapeutic blood monitoring, look at concurrent psychiatric and medical conditions, and look at environmental stressors. So it's pretty simple, but John Rush has a real eye for spotting something that needs to be said, and I think difficult to treat depression is a very good concept. So good that the slides have vanished. So, yeah, sure.
In these groups that you have described, how common psychotic symptoms are?
Well, that depends what you mean by psychotic symptoms. With psychotic depression, there's two schools. There's a very narrow school, which says that you've got to have almost Schneiderian first-rank symptoms. And then there's a broader school, which say that even negative cognitions would count as psychotic. So it depends on your definition, as in all these things. If you look at the very narrow concept, it's really quite rare. If you look at the broader concept, which actually gets so broadened as to almost be meaningless, it's really quite common. So psychotic symptoms are, psychotic major depression is one of the subdivisions. One of the others is, of course, bipolar depression. Now, one of the things that's very often not fully realized by trainees is the diagnostic criteria for a major depressive episode are the same for bipolar depression and a major depressive disorder. The only difference, of course, is that in bipolar disorder, you have a history of mania or hypomania. So that's a crucial point. The other subdivisions, which to my mind are important, are, of course, the recurrent, the unremitting, and also the so-called atypical group, the group who, instead of having reduced sleep, have increased sleep, instead of reduced appetite, have increased appetite, and so on and so forth. This is called atypical, but it occurs in maybe 35% of people with depression, and even more in bipolar depression. So we're just gearing up again.
Yes, I think he's the projector of that stuff. As you know, I'm a psychosis person, but psychosis can come with mood disturbance. But if I think about my training in psychiatry, the most severe cases of depression, that's why I ask you about psychosis, with very pervasive delusion of guilt and nihilistic delusion, were actually postnatal depression.
Oh, absolutely. Postnatal depression can be incredibly severe. You also get lots of psychotic depression in the elderly and lots of psychotic symptoms. And of course, our use of ECT, which I'm going to come on to, is increasingly in the elderly. Okay, well, maybe I'll just carry on lecturing.
I wonder if there are any
We can do questions now.
Yes, we can do some questions. Thank you.
Thank you so much until this point, at least. Maybe we could, in the beginning you said that in your opinion, depression in the elderly differs significantly from depression in the young. Can you elaborate on that a bit?
We've been doing work on this for about 3 or 4 years, maybe longer, and it comes from initially the observation that the risk of a dementia is increased if you have a depression. But paradoxically, or so it seemed to me at the beginning, that this is not related to a lifetime of having depressive episodes as strongly as it is to having a late life onset. Now, late life, some of us will be pleased to hear, has a definition which seems to float about depending on the age of the definer. But it's probably, I'm sorry to say, somewhere in the 50s. We've looked at this in terms of therapeutic studies. There's a body of literature suggesting antidepressants don't work as well in elderly depression. ECT does, but antidepressants don't. When we've looked at some of the data from the trials, it seems as though the therapeutic signal is much reduced in individuals who have their first episode of depression after the age of 50. Why would that be? Well, it's likely to be a prodrome or in some way related to the long onset of depression. In bipolar disorder, we've also looked at people with a first episode after the age of 50. So no depression before, no mania before. And they have much less of a family history, suggesting less genetic loading, and a much higher rate of organicity. So it looks as though somewhere around about 50 to 65, depending on your definition, the first onsets of depression are different. And this is important for trials as well. So one of the studies that I'm going to show you is about ketamine, nasal S-ketamine. In the initial study in the elderly, nasal S-ketamine didn't separate from placebo. The definition of depression didn't take into account age of onset. In the most recent study, which is not yet fully published, the definition of elderly depression, the first onset had to be before the age of 55. You could be 65 or 70, but you had to have your first onset before 55. And there was a much clearer and significant separation from placebo. So I think this is important, particularly for therapeutic studies. Again, defining the population of depression is absolutely vital. Just taking it as one big bucket doesn't particularly help. Okay, I'll carry on, and I'll carry on with my memory of the slides. Oh, Robin's going to help me here.
No, I'm going to apologize to the people online about the... well, people here know our difficulties, but the people online are wondering whether their electricity is not working or their internet.
I think it's actually Alan's fault, because we always started with psychosis, the forum. Whenever we opened the forum with psychosis and schizophrenia, we never had any technical problem.
Well, my first professor of psychiatry on a ward round used to say to the trainee, put the notes down and tell me what you really know about the patient. So this is a challenge. So I will attempt to give my lecture without the slides until the slides appear. So shall I do that?
And then we'll mark how successfully.
Thanks, Robin. Okay, so there's a couple of other factors in terms of looking at studies which I think are important. One is the placebo response. Now, this has been taken to be nothing more than an irritant, but in actual fact, I think it's extremely important and therapeutically potentially beneficial. So Professor Phil Mitchell from Sydney years ago produced a paper called Placebo Effect, Boon to Therapy, Good for Therapy, but Bane of Research. But that means that we should be researching into the placebo effect. Now, the placebo effect seems to have a number of different components. There's a component which is really the spontaneous resolution of the illness. If you include lots of first episode depression that a likelihood of lasting, say, 2 to 3 months, in a trial, there's going to be spontaneous resolution. So that's not really a placebo effect. That's a regression to the mean or so on and so forth. The other component, apart from the active therapeutic component, is the placebo effect. Now, we've tended to dismiss this as being nothing more than an irritant, but in actual fact, not only are there psychological factors which may be of great importance for thinking about how therapy works, but also there may be biological factors at play. When I worked in Vancouver, I did lots of research with the Parkinson's doctors, and they did therapeutic studies of dopaminergic drugs in Parkinson's. And then they looked at PET scans, something that we have great experts in the audience. And very interestingly, the placebo responders with Parkinson's showed an increase in dopamine turnover. So the placebo effect may have a psychobiological component as well as a purely psychological one. The other thing that we can do is we can look at the placebo effect by blocking studies where we have already achieved a response. So one of our colleagues in Center for Affective Disorders, Luke Jellin, who's doing a PhD, he has a study looking at ketamine responders and doing a double-blind, placebo-controlled blockade of this with an opiate antagonist. And I think we should be doing more research looking at placebo responders and blocking of effects. The other factor, which I think is extremely important in thinking about trials, which almost never gets addressed, is patient preference. So there's good work from Massachusetts suggesting that if you really want psychological treatment, talking therapy, and you get drug treatment, your response rates are much lower than if you get the therapy that you want. And if you really want drug treatment and get psychological treatment, the same is true. We never examine patient preference for therapy in studies. And I think this is particularly true for some of the talking therapies, where the patients who are recruited really want talking therapy. So those are two background main factors. Then my slides, which you can't see, neither can I, are going on to look at hot topics which are arising in mood disorders. Now, the first one is rapid intermittent treatment with antidepressants. So at the moment, the paradigm is you get CBT or SSRIs or the combination regularly for a prolonged period of time. If your first episode of depression, you get that for 6 months after you're well in terms of the medication. If you're recurrent, you get it for at least 2 years. We're moving to a model where people get a one-off treatment, and this started with ketamine but has gone on to psychedelics, and there's other treatments coming in that may have enduring effects. Now, I think it's very unlikely that people with severe mood disorders will get one treatment and that will cure them for life. But we may be entering an era where people get intermittent treatment every few months. And indeed, some would argue that that's what people have been doing with psychedelics on the street. Now, we're going to hear a lot more about psychedelics from James Rucker, who's sitting there, who's in our group, and is fondly imagining himself giving one of the subsequent lectures, but with slides. So I'll leave the psychedelics to James, apart from to say that it's a very interesting area, but it's in danger of being over-promoted. So in the last few days, we've seen another flurry of interest in psychedelics, with politicians telling us that this should be made available because it will cure depression. Now that is ridiculously early, in my view. We need to have a medical, scientific approach to evaluating the benefits and harms of all new treatments, and that includes psychedelics. So going back to ketamine and S-ketamine, so of course many in the audience will be aware of glutamate and the NMDA receptor with psychosis. I first came in contact with the NMDA receptor in the late 1980s doing my PhD when my lab was next door to Professor Richard Morris's lab, which was looking at the NMDA receptor in learning and memory. And even back then, there was a notion that the NMDA receptor was going to be important for the mechanism of action of antidepressants or novel antidepressants. And indeed, Ian Reid, my colleague at the time, another psychiatrist who was working with Richard Morris, Ian sadly died a few years ago, produced a whole theory about ECT working via the NMDA receptor. So this had a long, slow burn until Husseini Manji joined Johnson & Johnson and really led the whole program to make S-ketamine a licensed treatment. Now, you might say that we know that the racemic mixture is efficacious, but the total number of people in trials with the ketamine infusion is about between 200 and 300. That would never be accepted by the FDA or the EMEA for licensing purposes. S-ketamine, the racemic mixture, went through all of that and has a license for treatment-resistant depression. It's not been taken up very widely because it's very expensive, but nevertheless, it's the first really new treatment that we've had for treatment-resistant depression in really decades. So I think it's the first of the new. Now, a key question of any new treatment is where it fits into the treatment pathway. So S-ketamine is very expensive. Is it any better than our standard augmentation options? Now, the first thing to say is that I'm just looking in case my slides up here. Professor Tony Clear and I have done a study called the LQD study, funded by our National Institutes of Health Research. This is really Tony's study. This looks at people who failed 2 antidepressants, and then we've augmented them with lithium or quetiapine. Now, I'm a great lithium advocate. I was firmly convinced that lithium would beat quetiapine, but across the board, quetiapine beat lithium on every outcome. Why is that important to ketamine? Because Johnson & Johnson have done a study with the same design. Remember, we did failure to respond to 2 antidepressants, lithium or quetiapine. The ESCAPE study is the same design, but quetiapine or S-ketamine. And S-ketamine beat quetiapine, put very simply. So it looks as though there's a hierarchy here.
Could I have your presentation? We're trying a different computer. Sorry about that. The good news is that you can, rather than sleeping tonight, you will have a link where you can access Professor Young's slides. And then I will quiz you tomorrow to see.
It's MMF final. So in the ESCAPE study, S-ketamine beats quetiapine. In the LQD study, quetiapine beat lithium. Now, it's still possible that the final recommendation may not be for S-ketamine, because if you look at the health economics related to the expense and so on, then it may well be worthwhile going through a number of other steps first. But nevertheless, that's the current hierarchy of effect. Okay, trying to remember the rest of my slides. I've done rapid-acting antidepressants. James is going to do psychedelics. I also mentioned digital. Oh, Oliver.
Just on your lithium quetiapine study, can I ask, was that augmentation?
Yes. So they were both augmentation studies. So they're both studies where people failed on 2 antidepressants. They're very pragmatic, because what clinicians tend to do next is add an augmentation. So they were both augmentation studies. Question, so behind you first. I'll repeat the question. So the question is about ECT. Now, one of my slides is our current depression treatment pathway, which includes ECT. And when I get down to the end of my slides in my head, I talk about ECT. So, question there? It was probably about 40% better. Yeah, it was quite, than quetiapine. Yes, it was, yeah. It was enough to be clinically significant, I would say. Question here?
When I started doing psychiatry as a registrar, I was told that you had to have a 4 to 6 week wait to see if an antidepressant was going to be effective. And later on it emerged there was a subgroup who would have a response earlier, perhaps 10 days into it, and that correlated with variants of the serotonin receptor, whether they had the long tail or the short tail. Can you comment on that, please?
I'm not sure the long tail and short tail of the serotonin receptor has been replicated, but the burden of evidence is, and this is a meta-analysis by Zagedi, that if you don't show at least a 20% improvement on your depression scores by 2 weeks, then you only have a very small likelihood of responding. Now, there are late responders, and I'll show you, if I ever get to it, a slide that shows that in the ESCAPE study. But the point is that clinically, people leave patients far too long. So patients will be left for 6 months. I mean, we did a survey in South London, Roland Zahn and I, and discovered that the commonest thing that happened after people were started on antidepressants was to do nothing more. People hadn't responded. They were never even reviewed. So we should review early. Here we go. So just to say that for people who do have TRD, we have standard treatment strategies that we do at the moment, including augmentation that we examined in the LQD and ESCAPE study, combination, so on and so forth. These strategies are common in clinical practice, but evidence supporting their efficacy is limited. Now, the lady at the front made a very important point about when you should consider changing treatment. But we all say, the BAP guidelines, all the other guidelines say, review between 2 and 4 weeks. Active review is important. Matthew Taylor, who worked in the Institute before going back to Oxford, did a very nice study showing that there is change in the first 2 weeks with standard antidepressants. So this is what I was saying about the ECT. So this is our current treatment strategies for patients with major depression. Screen and diagnose SSRI or SNRI. Inadequate response, you should be looking in the APA CANMAC guidelines for that very early. After 2, then it's a carousel of treatments. So it's not a series of treatments that you have to go through like a Via Dolorosa. It really is an option where you can personalize it. You can add CBT or other psychotherapies at any point. Indeed, you can do these initially. You can combine antidepressants. There is some evidence for that for particular antidepressants. Or we augment with atypicals, lithium, and quetiapine. And that's what I've just spoken about. With inadequate response, people talk about ECT, TMS, and VNS, but I'll leave that till I come on to those slides, hoping that they don't disappear again, and I have to check my memory. So this is the challenge of major depression. In high-income countries, such as ours, 1 in 5 get minimally adequate treatment. This is from Graham Thornycroft. And in low and middle-income countries, it's 1 in 27. So although we do have treatment paradigms, we have a treatment pathway that's accepted, we're really poor at doing this. Now, this was a study by Graham about 6 or 7 years ago. We did this again for the European Brain Council with Jonas, who's in the audience, was one of the group here, Jonas Ebhard and others from across Europe. And these are the headline results across Europe. Now, the UK was not particularly good, was not particularly bad. It was somewhere in the middle. So I'm afraid we're unexceptional. We probably would get a B minus, but no one would get an A. 52% detection of depression. Of that 52%, 62% were treated, 33% had good follow-up, and access to secondary care, which means psychiatrists, 19%. Access to psychological treatments was even lower. So although we have a theoretical treatment pathway, putting that into effect is very difficult, and we're arguing against other areas of medicine. We're arguing against childhood cancers and so on and so forth. If we say to our government, we need more money to be spent on mental health, our Chancellor of the Exchequer would say, well, what do I take it away from? So this is the future treatments. I want to talk about digital first, and I can deal with that. I've gone on to rapid acting, so you can tell my memory's not perfect. I'm going to talk about neuromodulation, different types. I'm going to talk about probiotics and the gut, and I'm going to talk about lithium. And hopefully, I'll still finish reasonably in time. This is what I was saying about the placebo effect. This is from a nice paper very recently that Luke Jellin sent to me. This is the perceived placebo effect, spontaneous remission, and so on and so forth, Hawthorne effect. The true placebo effect, which may have a biological component, if you think about the Parkinson's studies, and then the active treatment. Now, the clinician and the patient benefit from the totality of this. And I actually think that we've been rather foolish by not maximizing the placebo response for our patients. A key to this is a good therapeutic relationship with the same healthcare professional. But I think looking at this is a real focus for further research. And this is the patient impact. So this is what I was saying about patient preference. If you're someone who really wants the new talking therapy and you are put in a trial for the new drug, your likelihood of response is very low. So this is from Papakostas and Koskas. These aren't randomized between the groups, but if it's a medication trial and you receive, for example, psychotherapy, and your preferences for medication, your response is much lower than if it's medication or combination. Look at the difference between if your preference is psychotherapy and you receive psychotherapy compared to receiving medication. We never talk about this in studies. This is incredibly important. We should be thinking about this and trying to take away this source of variability in studies. Right, digital. Now this is quite quick because this is probably the area of greatest uncertainty, at least in my mind. The possibilities for digital are huge, but in actual fact, we don't know how it's going to pan out. I was at a dinner party a couple of months ago. A lady sitting next to me didn't know I was a psychiatrist. I asked what she did. She said she had a new mental health app that was going to cure depression. Her and her husband had worked for an airline, were made redundant, and went into setting up a depression app. There's thousands of these out there, and their efficacy is questionable. So here's the potential things that might happen in the future. There's mental health apps, of which there's many. These are going to be good for monitoring, but they're essentially going to be unregulated. Whether they will really aid the detection of depression or produce a lot more false positives is questionable. Robotics, I'm quite looking forward to robotics and having a therapeutic companion. Gaming has got both disorders and potential therapeutic uses. Virtual reality, there's been a bit of this done in the Institute, both in terms of assessing people, particularly neuropsychological function, but also delivering therapy in a virtual reality setting. Who here is a Star Trek fan, apart from me? Right. Well, you'll all know about the holodeck. And conceivably, you could be getting your psychotherapy from Dr. Freud at some point in the future. Artificial intelligence, in terms of research, prediction, prevention, and diagnosis, is undoubtedly going to be huge. The rate of development of AI, I think, has reached a crucial stage and is really, it's like a rocket taking off. Where it's going to be this time next year, we don't know. Never mind 10 years' time. Social media, this has very deleterious effects on mental health. If you have teenage children, you'll perhaps be aware of this. This is, I think, behind lots of things that are happening in child and adolescent psychiatry, including increase in self-harm and so on and so forth, exposure to pornography. Digital phenotyping comes with AI. And then we've got neural implants, which is associated with Elon Musk, but may well happen. We may well have things like this. It may be led by things like Parkinson's, but it's going to come to our field as well. Of course, one is to deliver psychotherapy. This is just the evidence that CBT added to antidepressants give an extra boost, or vice versa. Indeed, my colleagues in the Netherlands say that they are considering making the first-line treatment for depression the combination of CBT and antidepressants. Now, that would certainly be evidence-based, but it's going to be very expensive. In Germany, a year's SSRIs cost 80 euros. A session of CBT costs 80 euros. So I suspect it's still going to be SSRIs first. This impacted our own research. We had a grant for doing mindfulness-based CBT in a group setting, which was due to start in March 2020, but something else happened in March 2020. So we had to rapidly change it to an online setting. And the online group delivery of the MBCBT seems to have worked very well. Now, we don't have the full data yet. We haven't quite finished the trial, but the format seems acceptable. So there's going to be big changes in detection and delivery. Now, I've been through this. This is just to show the pharmacological therapies for mood disorders. I was going to ask Robin, because Robin likes putting me on the spot, so I'm going to put Robin on the spot. This is one of the first trials in mood disorders in a randomized controlled way between Davies and Michael Shepard, Lancet, 1955. Robin, what was the medication?
The medication must have been chlorpromazine. Perhaps not a surprising answer. It was reserpine.
And reserpine showed a therapeutic signal for depression. And we've just done a meta-analysis of all the reserpine studies published in the Journal of Psychopharmacology. Not, they were all published, but we published our meta-analysis. Reserpine, every medical student will tell you, causes depression. If you look at the studies in the round, there's just as many showing it helps depression as causes depression. But from then on, all of the antidepressants and treatments were basically in this mechanism of action paradigm, increasing serotonin, noradrenaline, blocking dopamine, and so on and so forth. This is a very simplified version of the glutamate type approach with the GABA inhibitory neuron, the glutamate surge, the AMPA receptor, perhaps finally affecting BDNF. So this is a new model, if you will. And there are numerous treatments working on this, different parts of this diagram. Brexanolone works here. There's ketamine effects, S-ketamine effects here, and there's new drugs being developed by others. So this is the background. This is the S-ketamine data showing that compared to a placebo, now they were, going back to Oliver's question about augmentation, in the S-ketamine studies, they were all on new antidepressants plus the S-ketamine nasal spray or placebo. And you can see it's separated, perhaps not that impressively, but this was maintained over following a year or so. This is the ESCAPE study that I mentioned. Now, the LQD study that Tony Clear did, same design, but instead of quetiapine versus S-ketamine, it's quetiapine versus lithium. Quetiapine beat lithium. In this study, S-ketamine beat quetiapine. Now, you asked about the magnitude of the effect, and you asked about the onset of effect. This is actually really interesting in this diagram because it shows, to some extent, both. So if you look, this is the acute phase up to 8 weeks, and then the continuation phase up to 32 weeks. This is the S-ketamine, and this is quetiapine. You can see it beats it at 8 weeks. But also, both groups, there's an increasing benefit over 32 weeks. But that's greater. And I said about 40%, so it's roughly a difference, 40% extra, probably. We'll have to look at the paper to get the exact figures. But this is interesting because this is a nice design, because this looks not only at achieving remission, but maintaining it. And that's a much more clinically practicable and helpful measure. So this is psychedelics. I'm just handing this over to James. And in case you can't identify James, who's sitting in something like the 6th row, this is him here. And this is the rest of the attractive, charming, and clever psychoactive group. Right, I'm going to talk about neuromodulation here. This, to my mind, falls into two camps. There's ECT and vagus nerve stimulation. Now, ECT, Julian Mutz, who was our master's student, who's a PhD, I think he's a postdoc now in SDGP, did a nice review in the BMJ in 2019 showing that bilateral ECT is the most effective treatment for depression. Despite all of the stigma and attacks from the anti-psychiatrists. Vagus nerve stimulation, which is widely used for treatment-resistant epilepsy, also has good evidence for the very severe end of the spectrum, particularly people who respond to ECT but then relapse when ECT is stopped. That's the group who do really well with VNS. It's not used very much in the UK because it's expensive. It's used a lot in Germany because the Germans have accepted the idea that this will actually save money. And then at the milder end of the spectrum, we have TDCS, trigeminal stimulation, and probably TMS. So TDCS, trigeminal stimulation, I think are antidepressant. They're probably, despite the hoopla, not any better than antidepressants for CBT, but others will claim differently, including Sky News. TMS, to my mind, has never displaced ECT. I'm unconvinced about this. There was a recent headline about new super effective treatment for depression, for treatment-resistant depression from Stanford, from Nolan Williams, who I know quite well, published in the American Journal. It was based on two groups, One had 14 patients, the other had 13 patients. So this is no more than a straw in the wind. And even theta burst and so on, it's not as efficacious as ECT. And vagus nerve stimulation is approved as a device. The long-term registry studies show good effects, but because it's so expensive and because it's invasive, it's going to be used very sparingly. This is the flow neuroscience. This is the TDCS. I should say that I'm on their scientific advisory board, and Cindy Fu has done a very nice trial, which is not published yet, but shows that this is antidepressant convincingly. Nevertheless, if any of you can bear to read the Sky news story, which came out yesterday, I was preparing these slides, and my wife said, "Oh, have you seen this?" And this is the link here. The claims that are being made for this are really almost too good to be true. So it's more effective than existing depressive treatments, and it keeps people well in the long term. I doubt that's true, but because you can go online and order this right now, if you can pay the money, then people will be treating themselves with this. So it's a very scalable therapeutic intervention. Indeed, the chairman of the company, who's a very nice young Scandinavian man, wants to treat the whole of the population of Greenland, because Greenland has the highest rates of depression in the world, with this device. Okay, probiotics. Given that we're in a part of the world that's so good for food, I thought I'd introduce this. So the gut-brain axis, bidirectional communication, partly through the vagus nerve, which has got a strong component taking signals from the gut to the brain, and this may be related to VNS action, the immune system, and the endocrine system. Now, this is a review that was done by Victoria Nikolova, our PhD student in JAMA last year, and she reviewed all of the composition of the gut microbiota and psychiatric disorders. Quite a lot of evidence of transdiagnostic patterns of alteration in MDD, bipolar disorder, schizophrenia, and anxiety. So there's something here going across psychiatric disorders. Now, if you're old enough, like me, you'll remember there were lots of spurious findings. I'm sure Robin remembers this. Spurious findings from inpatient psychiatric patients related to biological findings that turned out to be due to diet and so on. But nevertheless, there may be something here that's going on, and it may well interact with the genes. As potential treatments, now, I view the probiotics treatments as being a bit like Coca-Cola or Pepsi. So you can't patent the individual components of the composition, but the blend is actually secret. So that's how it's monetized by the companies. But this is the updated review and meta-analysis of probiotics, and you can see that there's a signal of efficacy, particularly for depression. Probiotics significantly reduce depressive symptoms, particularly when administered in addition to antidepressants. So that's the overall review that Victoria did. And that's another one that says the same. This is her study where she did 50 people. I mean, this is a magnificent piece of work by a PhD student because it was done during COVID, and she got 50 people. We all confidently expected it to show nothing because it's only 50 people. Victoria doesn't want me to say what the results are because they're not published, but it's going to be published in a high-impact journal, JAMA, which you don't usually get with small negative studies. So very interesting piece of work. Okay, I want to finish up with lithium. I haven't talked much about bipolar disorder at all, despite the fact that the two main components for psychiatrists of mood disorders are treatment-resistant depression, which I've majored on, and bipolar disorder. Lithium is our oldest treatment by a long way because it's an element. It was created just after the Big Bang by God or nature, depending on your belief system. And it's in all of our environments. Remember this when people scoff at the effects of environmental lithium on suicide rates. It's there from before conception right through to death and can alter brain function, undoubtedly. But as a therapeutics agent, it's fallen into disuse by psychiatrists, especially in North America and increasingly in the UK. Now, this is a great shame because lithium has its disadvantages. It can have effects on the kidney and the thyroid and so on. But for many people, it's a game changer for the patients. Now, this is a review which is not yet published. It comes out in the next month or two. It's rather small print, but we looked at the entire world literature comparing mechanisms of lithium treatment efficacy in people with bipolar disorder. Well over half of the people treated in all of the trials had a good outcome. Now, that is incredible. And the reason that we're not using this more is mysterious. The reason that the MRC and the other funding agencies aren't putting major funding into trying to work out how lithium works really baffles me. But the European Union has done this with us and with Franck Bolivier and colleagues across Europe, and some of whom are in the audience. Jonas again. This is the R-Link study. This is an attempt to look at personalized medicine, identify the individuals who will show an excellent response to lithium. Now, when we wrote this grant, we didn't have the benefits of the review, which we've not published, but looking at the literature, about a third of people with bipolar 1 will have an excellent response to lithium, a third have a partial response, and a third have no response. If we could identify ab initio those who are not going to have any response or those who are going to have an excellent response, it would be a great advance. And it's really the first major attempt to do personalized medicine in mood disorders. And it was a reasonably large grant. Tony David was the head of academic psychiatry at the time, and I swear when we got this grant, Tony almost smiled. And these are the individuals who are helping us. It's really headed by Franck. There was a debate about whether Franck or I should be PI, but as Brexit was happening, we thought it might maximize our chances to have someone who was actually a European. And this is a very simple schematic of what we're doing. We're doing biomarkers of lithium response, actimetry, ecological-based measures, pharmacogenetics, molecular signals, and brain lithium distribution. David Cousins, who trained with me in Newcastle, still in Newcastle, runs the MRI unit. Lithium's response may be as simple as the people who get decent levels of lithium in the brain. David's work so far shows there's a very poor correlation between peripheral lithium levels and brain lithium levels. Now, that would be too good to be true were it that simple, but one never knows. We've finished the study, we're analyzing the data, and we'll be reporting on it soon. So, going back to my current treatment strategies, this is our Maudsley pathway. This bit here is going to change greatly. I think we're going to see lots of detection of depression with apps and so on. You can already get the PHQ-9 for your phone. Whether this produces more false positives, more people talking about their mental health who are not actually suffering from mental ill health, remains to be seen. We're also going to see a lot more treatment here with things like the flow neuroscience device, probiotics, and so on. That's not that new. Remember, in parts of Europe, people are advised to take St. John's wort first before they go on to formal treatment. It's going to be a different kettle of fish when you get to treatment resistance. We're seeing new treatments related to ketamine and so on. It's possible that some of the other areas I've mentioned may be important. I mean, what they may actually do is reduce the amount of treatment-resistant depression. If it's detected early and treated, it may well work. Some treatments we're not really sure where they're going to fit. James will talk about psychedelics, which have been looked at in TRD, and VNS and ECT remain important. And lastly, this is a whole area where we as psychiatrists need to not only understand conceptually what's going on and the evidence base, but we need to advocate for it in the public forum. In mood disorders, we are seeing increasing misuse of meta-analysis and systematic reviews. Perhaps the most egregious was John Moncrieff's serotonin debunking in molecular psychiatry where they'd left out important positive results, for example, the PET studies. So we've got to be aware that we've got a huge amount of information. This feeds through to knowledge, but really we need wisdom to understand the field and to try and help our patients best. Thank you very much.
Thanks, Alan. One, for an excellent lecture, and two, for overcoming amazingly well the difficulties with the slides. First of all, an online question. Could you please specify the dose of quetiapine for non-responding patients?
300 to 600 milligrams daily XR. It was, in the ESCAPE study, it was 300 to 600 milligrams, between 300 and 600 milligrams of the quetiapine XR. It doesn't really matter to my mind whether you use the XR or the IR. The dose that you use of quetiapine in augmentation is much less than an antipsychotic dose. Years ago, Joe Calabrese and I looked at the data for bipolar depression, which was looked at 300 and 600, and you get about 95% of the effect of 600 with 300. So there'll be the odd patient who needs more than 300. Possibly they're fast metabolizers, but generally the lower doses work.
And then, Alan, the same person is asking, what about evidence for mirtazapine or trazodone in add-on to SSRI or SNRI?
So in South London, that glorious oasis where we all work, or many of us work, it's very common, and very common throughout the UK, for GPs to do combinations of antidepressants. The combination that's evidence-based is mirtazapine plus a reuptake inhibitor. Combining bupropion and an SSRI hasn't been shown to have any extra benefit, but mirtazapine or mianserin, which people don't use very much because of the blood dyscrasias, plus an SSRI is the evidence base, and that's fairly effective. We almost never do that in our clinic because they come to us usually on that or having tried that. Of course, there is an increased side effect burden, especially with weight gain and sedation from the mirtazapine.
Could you comment on augmenting with agomelatine, which has got a different way of functioning, with a SSRI, for instance?
So agomelatine, it's a real, I mean, it's almost like some biblical parable of drug development, because this is a drug that's got a novel mechanism of action. Basically, it's like a combination of trazodone and melatonin, so it's melatonergic, and it's got 5-HT2 action. The trials show that it's really very well tolerated. It's actually very good for sleep, but with no hangover, because it's got such a short half-life. Its side effect overall profile is about the same as placebo. It always seemed to me to be the perfect GP antidepressant, but it had a tiny increase in, a tiny percentage of the patients in the trials showed an increase in liver enzymes, and for that reason it's got a requirement on the label to do serial blood tests. That killed it in the UK and many other countries, although it's still used quite commonly in France. I'm not aware of any trials of augmentation of other antidepressants with agomelatine, but I know that my colleagues in Germany and Austria do that quite a lot, and I've inherited some patients from them where, based on what the patients say, it seems to be helpful. But I don't think there's much of an evidence base.
Another question from online is, what about modafinil? Oh, excuse me. Right.
So it's your line manager, Robin. Yeah, we use a lot of modafinil to augment antidepressants. Modafinil is actually really well tolerated. We particularly use it for augmenting where there's more of an atypical pattern, so fatigue, sleepiness, and so on and so forth. We find it very useful, and it does have somewhat of an evidence base.
Hi, it's Alex Butt from St George's. We're still keen on the biopsychosocial approach. What about social interventions like debt advice or social prescribing?
Well, I mean, I think lots of things work, and that's why I like to we're all keen on the biopsychosocial model because the biopsychosocial model was invented by psychiatrists, and we all look at those things. It's part of our formulation. If you look at the group of people who are first episode or likely to spontaneously remit, they'll respond to anything. I think they need to have decent trials. I mean, this is one of the frustrations of the way the media treats depression. We get people saying, well, you know, I was depressed and I took up yoga and that helped me and I've never been depressed since. Well, you were lucky because you fell into the group that had one episode only. That's very different from the group that has the recurrent, and for the group that has the more recurrent, more severe, I'm afraid to say the more biological part of the biopsychosocial model pertains. And I can't see that changing.
But what about if you have an alcoholic spouse or you have a child with chronic leukemia? Do any of these studies take into account the social pressure that the sufferers are under?
Not really, and there's lots of problems with the trials, especially in North America, where, you know, people are rewarded on recruiting, there's professional patients and so on. There's certainly studies, and we took part in some of these, that looked at carer stress. And if you're caring, for example, for someone with dementia, then your level of stress hormones is as high as the melancholic depressives. So there's no doubt that this is a significant. And if you go back to John Rush's difficult to treat depressive model of how to help these patients, there's clearly an aspect of what you're saying in there. I mean, I've got a patient who's generally quite well, but he has a relapse every time his mother-in-law comes to stay. I've been unable to change that, but it's clearly an association. Sorry, Robin, I wasn't talking about you there.
When you started off characterizing the different subtypes, I didn't quite capture if you had PTSD within the mood disorders and how much that would also potentially confound the tapping into the other types and affect outcome.
Yes, I mean, the genetic correlation one did show a relationship with PTSD. We're increasingly seeing a lot of PTSD in bipolar disorder. I do worry about PTSD and ADHD because they're in some ways quite easy to understand or perhaps easy to misunderstand. People are self-diagnosing a lot with them. But certainly PTSD is a comorbidity, yes. One of the problems with the trials, and you'll know this better than I, Jonas, because you worked in pharma for a prolonged period of time, is that people with comorbidities tend not to get into the studies, and therefore this very important group, which may even be the majority of patients, we've got a very meager evidence base.
I'm wondering if you can comment on the use of Cytomel T3 as augmentation.
Comment on what?
Cytomel T3.
Oh, T3, yes. So there's a T3, T4 debate. Certainly, Michael Bauer, we have a link up with Dresden from King's Transcampus, and Michael Bauer has done lots of the studies with T3. It was actually in my Maudsley pathway. You could see there was augmentation with thyroid hormones. It works for both bipolar and unipolar depression. The evidence base isn't huge, but it's there. It also seems to be helpful if you give supraphysiological doses of thyroid for rapid cycling. The problem we have in the UK is that T3 either isn't very readily available or costs an awful lot of money. Therefore, most of us are happy to use T4 because the two are converted. But some purists, I won't say Professor Tony Clear, but it is him, feel that T4 is not as good. However, the people that did the T3 research are quite happy to use T4 rather than spend €3,000 a month on T3. So it's a reasonable strategy.
Last question?
It was a great talk. Thank you very much. I've always learned a lot. I have lots of questions. I'm going to ask you them afterwards, but I have one in particular. In my field, in young people, we see a difference between anxiety and depression in terms of the efficacy of most treatments, psychological and pharmacological. It seems to me to be similar, at least in psychological treatments in adults, and in some of the pharmacological ones. So they're bigger for anxiety than for depression. So is this what comes under the placebo response? Would you agree, first of all? Why is that? Does that change your treatment strategy at all? Thank you.
Yeah, I'm sure we could have a long chat about this, Gareth, but I think in terms of anxiety disorders, the one that really is the twin of MDD's GAD. There's a 90% lifetime co-occurrence, but I do agree, things like CBT seem to work better for anxiety than they do for depression. I suspect that maybe just that the therapies actually does have fundamentally greater utility in the anxiety disorders. But of course, lots of the pharmacotherapy works for both. I would actually, for trials, and no one's ever listened to me with this, but for trials, I would certainly include anyone with a comorbid GAD if I was investigating MDD, because I think they're so closely allied. Okay, I think everyone's had enough.
Well, actually, I have a question about sleep.
Oh, yes.
So sleep is difficult. I mean, of course, you can start people on antidepressant, you can do the augmentation, but often you don't have a quick effect on sleep, which is something that is very disabling. At the starting of treatment, Allan, do you use any add-on which are specifically targeting sleep, including some, now the Royal Colleges go an app for sleep hygiene, which with patients with psychosis I see doesn't seem to work very, very well. But do you believe in sleep medication? Do you use any specific pharmacological approach for sleep?
So, for patients who have sleep problems, I tend, and who haven't been through loads of different steps, so I do see people early in the treatment pathway, particularly doctors and so on and so forth. I do tend to start people on a regular antidepressant and trazodone. And trazodone actually works very quickly. It helps sleep, helps anxiety, and is very useful. There is the Sleepio app, which is quite hard work, and people do use it. And of course, you should tell people about sleep hygiene, but you've got to be careful you don't patronize people, because very often they know these things. There's also sleep deprivation as a therapeutic modality. This is actually quite popular in parts of Italy. Sleep deprivation does appear to be quite powerfully antidepressant. It goes in and out of research fashion. When I first went to NIMH in the 90s, there were 6 groups researching on sleep deprivation and antidepressant mechanism side by side in parallel. But no one is really looking at it now. David Veal has done something called, that we helped him with, called triple chronotherapy, which is sleep deprivation, bright light in the morning, and the sunglasses that block certain parts of the spectra. Now, this was an open feasibility study, but it had really powerful effects. So there's definitely something with sleep. The last thing to say about sleep, and this is quite contentious, I haven't really covered cognition because I would have been here all morning, but cognitive impairments are quite clear in both depression and bipolar. There seems to be a strong correlation with the sleep problems. So we're not actually clear what's chicken and what's egg with sleep and cognition. If you think about, if you've just come back from Toronto and you're now in a meeting in Palermo and you're having to organize all these difficult psychiatrists, the jet lag might interfere with your cognition. So sleep and cognition have an intuitive relationship, but whether they both come from something that's common underlying, it's one then the other, we don't really know. But I think that's something we need to be looking at more carefully.
And because you talked about this relationship, when I was an SHO, I worked for a psychiatrist. You might know Dr. Penrose, who was one of the old British Society of Psychopharmacology founder. And he would treat people with severe recurrent depression, and some of them would be in the elderly group with what he would call sleep therapy.
Yes.
So he had access to a nurse, so he could put them on heavy benzo for 48 hours with the nurse checking on them, waking them up, giving them food and hydration. I've never seen anything like this. I haven't seen anything like that again.
I think most people would go the other way.
But no, you haven't spoken enough. I was
back
actually
on.
wondering, Argyris, I know you had more questions. You can ask one more question. This is good for my daily steps. I'll ask.
So, Alan, if you could design one study to understand the so-called placebo effect, what would you do?
Well, I think it's pretty much, well, I did mention Luke Jellin's study of ketamine responders, and I think it's worthwhile mentioning that again, just because Alan Schatzberg said there was a component to the ketamine response that was dependent on the opiate activation, particularly the mu opiate receptors. Now, this is a very contentious area because of what's happening with opiates in the States. And if you say your drug is somehow related to that, even if the pharmacology is quite different, not related to dependence, it could be very difficult. But Luke's done a nice study which blocks the placebo response, blocks the ketamine response with placebo or with the naloxone. In terms of actually investigating the response, people have done open studies of placebo. So you tell people they're going on placebo, and then you look at the response. And immediately there is an effect. So I think keen on looking at the group of placebo responders and trying to block the effect, the placebo effect, double blind, with various pharmacological probes. And our first choice would probably be naloxone. You get placebo responders, and then you randomize them to get placebo or the blocker, and you look and see if there's a difference. And that will tell you if there's a component of the placebo response that's related to what you're blocking.
Alan, you mentioned in passing Joanna Moncrief and Mark Horowitz's paper saying there was no evidence for serotonergic abnormalities in depression. So my question to you is, does that matter in the sense that they implied that antidepressants shouldn't be prescribed because there's no evidence that there's an abnormality underlying them? And I think, does Oliver maybe also have evidence relevant to this?
He might do. We can ask him. So the first thing is, does it matter? Well, absolutely. We had personal friends who were on antidepressants who, after the headline, said, "Oh, I should stop this. There's no evidence they work." Now, first of all, it's a category error to confuse the evidence of efficacy with the evidence about the etiology or the biology. So first of all, that's totally wrong. Secondly, this had a big impact on patients who because they were hearing it from august scientific journals, thought, well, why am I taking this stuff? You know, there's no reason. So, I mean, I actually went to a lot of effort to convince patients and indeed friends that they should stay on their antidepressants. Next thing is about the evidence. Now, what seems to be happening, and the reason I put the T.S. Eliot slide up, is because I think systematic reviews and meta-analyses are being perverted by some people that are using them to their own ends. So basically, if you leave out the evidence that doesn't fit what you've already decided is the answer, then that is a perversion of the process. Now, in the 5-HT paper, the serotonin hypothesis debunking, they went over the PET work. I wasn't involved in the PET work, but I did examine the dissertation and refereed the papers and so on. It really worked quite well. They looked at the binding to the 5-HT1A receptor. They said in their paper that the serotonin hypothesis focused on the raphe, which it does, and there were no changes in the dorsal raphe or the cell body. That's absolutely true, but there were widespread changes postsynaptically, which were evident and reported in the paper. So if you have depression, your 5-HT1A receptors postsynaptically are reduced. Your 5-HT1A receptors postsynaptically reduced. That's in the papers, including the follow-up paper. Now, I reviewed the follow-up paper, and the authors, Paul Grasby and so on, were very worried that they hadn't changed the postsynaptic effect with treatment. But I said that makes perfect sense because these are recurrent, severely ill patients who still have the underlying biological diathesis. Now, that was left out of the serotonin hypothesis review by those authors entirely. And to my mind, if you do a partial analysis of the evidence and present it as a complete story, that is nothing more than a perversion of the process.
Yeah, I think I would agree with you regarding meta-analysis. In relation to CBT studies in psychosis, there are something like 25 CBT RCTs in psychosis, and there's something like 53 reviews and meta-analyses. And the people against CBT leave out the ones where CBT is positive. The people in favor of CBT leave out the ones where CBT is negative. So it's very difficult to tell the truth sometimes from meta-analysis. Oliver Howes, do you not have a study on serotonin in depression?
Is this working? Oh, it is. Yes, so when that review came out last year, actually they just beat us to publishing the first study with PET that tried to test whether release of serotonin was altered in people with major depression. And that was led by David Arizzo at Imperial. And that actually showed that people with MDD and also with Parkinson's depression show blunted serotonin release to a releasing agent in cortical brain regions. So that is evidence for this serotonin hypothesis that there is dysregulation in the serotonin system, as Alan said, in the post-synaptic parts of the system. So that's the first time it's been done with PET. We need to replicate it. But yes, already that review is completely out of date, apart from everything else.
Did anybody else have issues with patients who had read the paper debunking the serotonin hypothesis?
I do. And my one also have psychosis, but it was very interesting because they saw also some headlines, and I know James will cover these, on psychedelics, and said, well, this SSRI, I'd rather use psychedelics. Well, to me, the psychedelics, if they are effective, if anything, compound the serotonin hypothesis. If anything, they are very strong sort of activating of the serotonin system, as we will hear. So there you go. Alex, sorry, you had a question.
Alex is the one person who announced his name with questions, and it was my fault, really. I should have suggested to you at the beginning that when you ask a question or make a statement
Although he said, and I come from St. George's, where? St. George's in Paris?
I thought everyone knows that. In Tooting. It's in South London. Yeah, the other thing about, I guess, serotonin or SSRIs was the anxiety around the increases risk of suicide. I've had several patients that are really anxious about that and won't take them.
Yes, I mean, this was a big furore a few years ago. The FDA produced an analysis showing that there was no increase in suicidality age 26 and older, but a possible uptick in suicidal thoughts, but not completed suicide in 18 to 26. That's been followed up by an analysis by Professor Elias Eriksson from Gothenburg, who got the entire 6,000 patient database from all the SSRI phase 3 regulatory studies, and he's published a series of papers on it. If you look across the 6,000 individuals compared to placebo, there is no increase in suicide as measured by the suicide item on the Hamilton. So you've got to remember that people with depression have suicidal ideation. You know, it's very common, and people will kill themselves in trials. So I think at the moment we've got to be careful about it. If you go back to the beginning of the antidepressant era, it was always said that there was a vulnerable period early on in treatment when people were more activated, but their mood hadn't fully improved, and they were at greater risk of suicide then. There's also an issue about suicide and the psychedelics, and this is one of the things which needs to be determined in larger studies. But James will talk about that, I'm sure. But generally, I think we can be reasonably reassuring to our patients about that. But, you know, if you actually go back to what happens in the clinic, both in primary and secondary care, the guidelines all say that when you start people on antidepressants, you should see them between 2 and 4 weeks and then see them serially to monitor adverse effects and so on. Potentially that could be done by digital means, very, very practically. If you actually look at what's happening for very understandable reasons relating to the mental health services being in crisis, that just doesn't happen, by and large.
Could I just ask a question of that? One of the things that always perplexes me in the UK is that most people with depression don't see a psychiatrist. They are treated by general practitioners who have a varying knowledge or interest in depression, and we don't really know how well they are treated. Is that the same in most other countries, that most people with depression are not treated by a psychiatrist? Anybody from a country where most people see a psychiatrist?
Eric, what happens in Hong Kong?
I think, sorry.
Treated by GPs. Yeah. I suppose that is the question. Is that a good thing or a bad thing? So it's...
Yeah, so in...
This is Professor Chen from Hong Kong.
Hi, Eric Chen from Hong Kong. So people with depression actually mostly are not treated at all. So we had a recent epidemiological study of young people. So going back to Allan, so we look at MDE, so not just the persistent depression. MDE is about 13% in young people. And I think if you take the same sort of proportion who would end up in a persistent depression, maybe about 1/5 of them. Now, of all the young people with MDE, only about over 10% are treated by a psychiatrist or a clinical psychologist. The rest are not treated, not detected, most of them. So, so there's a huge access and recognition problem. The primary care in Hong Kong is not like the UK, so people don't usually access primary care for mental health problems. So mainly they would be treated by psychiatrists. That's right, yeah.
So if you look at the European study that we did, access to psychiatrists is quite limited across Europe. I think we do have a model of the way the care should be, and this is not unique to psychiatry. It occurs, for example, with diabetes, which is a collaborative care model, which is that you need to detect the abnormality. Primary care doctors treat it, but then if that's not working out, it's escalated to secondary care and then to tertiary care. I have a very good friend who's a diabetes consultant, and the similarities between diabetes and mood disorders are always striking to me. Collaborative care doesn't really work in the UK. It works in large HMOs in the US, which are one organization, but the escalation from primary to secondary care is actually very sadly lacking in the UK. And I don't think we can really necessarily blame the GPs. We can't really blame the psychiatrists either, because the psychiatrists have to prioritize the very limited resources to dealing with the most extreme cases. But that means that depression very often falls in the middle and gets neglected, I'm afraid.
I have two questions, sorry. I'm Naresh Button from South London Monthly Trust in London. You spoke about stress, cortisol, and depression. Has there been any research done to control the cortisol and treat the depression? And the second question was about seasonal affective disorder. Seasonal affective disorder.
Seasonal affective. Well, let's start with the cortisol first. I mean, I've spent probably about 30 years looking at this. there's really two patterns to our minds of the cortisol abnormalities. There's a group which are more Cushingoid with the high levels of cortisol, even though this is quite subtle. And the reason they don't appear Cushingoid is because they've got blunted glucocorticoid receptor function. So that's the classical high cortisol group. And they have been treated with drugs that block or reduce cortisol. And there's some work in psychotic depression about that, because that's the subgroup with the highest cortisol. The other group is the Addisonian group with low cortisol. And Tony Clare has looked at this in chronic fatigue and so on. And the group with atypical depression appear to be on that side of things. So again, depression isn't simple. There appears to be different aspects to it. It's also an area which unfortunately has become deeply unfashionable. And if you want to spend 6 months writing a grant and not get it funded, unfortunately do it in this area. But I think it's still very important. The other thing is about seasonal affective disorder. Well, there's a seasonal pattern which is more evident the further you get from the equator in terms of all of our biological rhythms. So you go into hibernation pattern in Scotland in the winter, for example. You eat and sleep more, and so on and so forth. This is very often superimposed upon depression. So you get almost a seasonal exacerbation of depression. Now, there's very good evidence that bright light works. So people have done placebo-controlled studies with the same boxes, but with different frequencies. Bright light appears to work for seasonal affective disorder, but it also works for seasonal exacerbations or even non-seasonal depression. I, however, have abandoned this in the clinic because I bought a series of light boxes years ago and I never got them back because the patients liked them so much. So I now give the patients the website and they go off and buy it themselves. It's not a miracle cure, but it's helpful for some people.
Last question?
Just a comment to, I think, Robin, you asked who is treating depression. I think in Sweden, I'm from Sweden, Jonas Eberhard, and we have a study done in the late 80s, early 90s of the deceased Wolfgang Rutz, who passed away recently, only a month ago. And Wolfgang, he did the educational program for the GPs on the island of Gotland. And one could then see a significant decrease in suicides there. And there was a lot of interest in this study. And I think educating the GPs about depression was one successful way of dealing with the problem. But it needed a boost, so it sort of wore off after a while. So.
Thank you, Jonas. No, there is another one as well that I promised. Last but.
Thank you. I'm Rose Anderson. I'm a child and adolescent psychiatrist from Sydney in Australia. And I just wanted to ask another question about treatment. Because young girls would rather do anything rather than put on weight, and quetiapine puts on weight. And is there any efficacy for using aripiprazole or brexpiprazole as augmentation of an antidepressant? Because that also doesn't give you the sedation that sometimes you want with someone who's agitated.
Yes. So all the atypicals augment antidepressants. They all use more or less the same mechanism, which is blockade of the presynaptic autoreceptor for dopamine, which increases release. So in some ways a similar mechanism to using a stimulant or modafinil. We choose it on the basis of side effects. So if people are anxious and not sleeping, we give quetiapine. If they are worried about weight and so on, we give aripiprazole.
Last question.
Thank you. Anna Clara from Sweden, Stockholm. Could you just say something about the correlation between ADHD and recurrent depressive disorder, but maybe also bipolar disorder, and the challenges in diagnostic and treatment?
Well, I've actually just been, not in Sweden, but in Denmark with colleagues lecturing about this. There's a strong comorbidity between ADHD and mood disorders. I come obviously from the side of the mood disorders, but it's clear that there's probably a significant proportion of our patients who've got complex or difficult to treat depression or bipolar where there's an underlying ADHD. There's a screening tool for it, which, like many screening tools, captures too many patients, but there is a diagnostic interview, the DIVA, which we use. We're actually doing a trial of stimulants in people with bipolar or schizophrenia with ADHD. So I think it's there, it's important. I think you probably are justified in using stimulants if you're clear in the diagnosis. Personally, I'm very worried about the concept of adult onset ADHD. That doesn't really make sense to me at all, but we're beginning to recognize, a bit like we're beginning to recognize a lot more that there's a lot of autism and anorexia. We're recognizing there's a lot of ADHD in complex mood disorders. Now, we're seeing an overdiagnosis of ADHD, perhaps. I mean, you could go online in the UK and get diagnosed and treated for ADHD if you filled in a questionnaire. That's a different scenario from someone who presents with a clear-cut, complex and difficult to treat psychiatric disorder. In that case, if it's a mood disorder, you should be looking and considering ADHD in your differential list of comorbidities.
And what about the treatment, like the steps? Would you consider antidepressant, like begin with it or parallel with
Well,
stimulants?
interestingly, when we were lecturing in Denmark, that was a key question from the audience, and the consensus seemed to be that you treat the area of greatest clinical need first. So you certainly do treat the mood disorder with your standard treatments, but you can also treat the ADHD, and it's up to the clinician's discretion about the order in which you do it, or you may even do it contemporaneously.
What about the choice of antidepressants?
Well, the one that's likely to do that is bupropion. Yeah, but I mean, I wouldn't think you could necessarily. I mean, bupropion pharmacologically is very similar to atomoxetine, or vice versa. But we have problems with getting bupropion. But many people with depression and comorbid ADHD really don't do well on SSRIs. So you may need to think out with the usual box of antidepressants.
Thank you very much, Alan. This has been a marathon. So I would like to thank you by clapping rather than I can't do with the microphone. So thank you very much. And thank you for all the questions and interaction. So now the good news is time for coffee breaks. Technology can't go wrong with coffee break, especially when it comes to Sicily. So it also gives you a chance to stretch your legs. Julia, Eduardo, and other colleagues will be at the door and will guide you because you're coming downstairs and going literally round the block to this lovely courtyard. I would be very grateful if you can come back on time. So if you can get your coffee, tea, cakes, you see some cakes, and begin then to gently come back. I will come and summon you anyway to make sure we're all here at 11 o'clock. Thank you very much.